Thanks for everyone for coming. So good to see a lot of you. Here for this session. You know, it's when we talk about the ISSs. There's like 5 in high-grade ovarian cancer, 4, and this is the 1 in low-grade cancer. So this is going to be the best one in low-grade cancer by far. Anyway, thank you. This session today is a new era in recurrent low-grade serous ovarian cancer, incorporating approved therapies, biomarkers, and clinical strategies. They give me a script to follow, but it's okay. So I just want to super thank, first of all, GOG for leading this. I want to thank the Greta Sackett and Linda. They should really be congratulated for running an incredible meeting. This is supported by Veristem, but the content is independent of Veristem, just to let you know. So my name is Brian Slamovitz. I'm going to serve as a moderator this afternoon. Here is the folks I just introduced. I'm from Miami Beach, Florida. Sackett's from University of Colorado. And Susanna Banerjee from the Royal Marsden NHS Foundation Trust from London. Here are our disclosures. Learning objectives are listed here. We're going to describe the challenges in managing recurrent low-grade serous ovarian cancer and understand the clinical complexities associated with this disease. We want to summarize the most recent clinical trial data and treatment options for recurrent low-grade serous ovarian cancer, including novel and FDA-approved therapies. How cool is it, FDA-approved therapies for low-grade serous ovarian cancer? It took us a long time to get there. We're also going to talk about investigational strategies, MEK inhibitors, CDK4/6 inhibitors, hormonal treatments, and other opportunities in the competitive landscape. Understand the role and importance of biomarker testing and sequencing in informing treatment decisions. We're going to discuss strategies for accessing newly approved treatments and managing associated side effects in clinical practice. Highlight future directions for integrating precision medicine and emerging investigational strategies in the care of patients with recurrent low-grade serous ovarian cancer. Here's our agenda. We are going to get through a lot of information. We've built in a fairly robust discussion, so we're going to really appreciate interaction from the crowd, so we could, you guys could give us some good questions, and hopefully we'll give you some good answers. We're going to stay on schedule. I want to introduce a case, and that think about it as we go along. When we get to the end of the session, we'll sort of go through these cases and have a better discussion, but we want to introduce hopefully some of the things we'll learn about. First case is a 34-year-old nulliparous woman with an unexpected ovarian mass. She had vague symptoms, persistent bloating, mild pelvic heaviness for 4 months. She had normal menstrual cycles, and she denied weight loss or systemic treatments. On workup, her CA-125 was 62. HE4 and Roma scores, if you use those, but they were inconclusive. No radiologic evidence of ascites or lymphadenopathy. On MRI, she had a unilocular cyst with mural nodules and enhancing solid foci. Radiologist said findings suggestive of borderline epithelial tumor. Early low-grade cannot be ruled out. Surgical event, planned laparoscopic cystectomy with it was escalated intraoperatively when the ovarian surface appeared irregular with excrescencies. Frozen section, as it is most of the time, was equivocal. Serous low-grade borderline tumor, serous borderline tumor versus low-grade serous carcinoma. Final pathology, low-grade serous ovarian cancer with classic papillary structures, psammoma bodies, and low mitotic index. There were no extra ovarian disease. Molecular profiling, it's important, and we'll talk about this. Next-gen sequencing detected a pathogenic KRAS G12D mutation, and the tumor was TP53 wild type, ER/PR positive, HER2 negative, consistent with this disease. Comprehensive staging revealed FIGO stage 1A, and we'll go through as we forward it the tumor board recommendations and follow-up. Second case is a 49-year-old woman diagnosed 5 years ago with a stage 3C low-grade after presenting with abdominal distension and omental caking. At that time, she underwent optimal cytoreductive surgery, followed by 6 cycles of carboplatin and paclitaxel, leading to complete remission. She remained disease-free for nearly 4 years while on letrozole maintenance therapy. Patient represented at that time with progressive abdominal fullness, early satiety, elevated CA-125 to 158. Imaging, the CT of the abdomen pelvis revealed multiple peritoneal implants, the largest measuring 3 centimeters. There was no ascites. A CT-guided biopsy confirmed low-grade serous ovarian cancer with papillary features and psammoma bodies. Molecular profile here, again, yielded a KRAS G12V mutation, NF2 loss, indicating activation of both the MAP kinase and the FACT signaling pathways. The treatment course, retreated with carboplatin and paclitaxel, achieving stable disease. Subsequent therapy with letrozole plus bevacizumab. She had produced a transient response before disease progression. Platinum-resistant, ERPR-positive, KRAS mutated, initiated on a dual RAF-MEK inhibitor in combination with defactinib. Now FDA-approved regimen, clinical course. At 8 weeks, she reported improved abdominal symptoms. CT scan at 3 months demonstrated about a 40% reduction in measurable disease, partial response by RECIST. Tolerability, mild rash, diarrhea, transaminase, and current status is she's sustained disease control at 4.5 months. Good performance status. And then now we're going to go into the details and we'll discuss these cases further. Without further delay, it's my honor and pleasure really to introduce my friend Susanna Banerjee to take us through the evolving clinical landscape and new treatment options of low-grade serous ovarian cancer.
Gosh, it's dark in here. Great. So I'm really delighted to be here in Cape Town with you and also talking about the progress we've made in low-grade serous ovarian cancer. So just to remind ourselves, low-grade serous ovarian cancer is a distinct disease. We've learned so much, and we recognize that ovarian cancer is more than one entity, and for this particular subtype of ovarian cancer, there are classic pathological criteria. Generally, patients who are diagnosed are at a younger age than, for example, high-grade serous ovarian cancer, and we know, sadly, from experience and trials, that the disease is less chemo-responsive. Generally, there's a longer survival than high-grade serous ovarian cancer. We've learned a lot over the decade with improvements in molecular techniques, that this disease does harbor molecular alterations, which we'll talk about a little bit more, in the MAP kinase pathway, but also the estrogen pathway. And just to highlight that BRCA mutations are rare, if present at all. And I do feel that when I do see a patient with a BRCA mutation and a diagnosis of low-grade serous ovarian cancer, if I were to, I'd want to review the histology to ensure this isn't high-grade serous. What we've more recently noted, and I'm sure we'll hear about this later, is that there is high folate receptor 1 expression in low-grade serous ovarian cancer, and that may have implications. So here we see a bit more detail of the MAP kinase pathway. I'm not going to go into every molecule here, but the key point is that there are multiple aberrations within this pathway that we know may be driving tumor growth, which we can target. So in terms of KRAS mutation rates in the literature, it's varied, but generally 20 to 40%. And there are other mutations of relevance, NRAS and BRAF, which in studies have ranged from as low as 5% to 33%. So I'm going to give a real quick tour of some of the clinical trials. And I really want to highlight the initial prospective phase 2 study of selumetinib. That was the first to report in the phase 2 setting, specifically in low-grade serous ovarian cancer, activity of MEK inhibitors. 52 patients, response rate 15%. And the activity in this study didn't appear to be restricted by mutation status. And you may say 15%. Well, we've seen so many higher response rates over, in other cancers, but as you will see, 15% was notably higher than what we seen experience, and also now we've got prospective clinical trial evidence with chemotherapy and also endocrine therapy. There's also other ways of targeting the MAP kinase pathway, for example, with dabrafenib and trametinib, and this was in BRAF V600E mutated low-grade serous ovarian cancer, and again, low numbers, but activity. So I'm going to highlight the MILO study, and this was the first randomized study, phase 3 study of binimetinib versus standard of care chemotherapy. And I want to note this study for a variety of reasons. I think it really showed that as a community globally, we can come together in a rare cancer which has been understudied for a variety of reasons, but mainly about time to recruit, time to get an outcome. And I think this study really showed that it's possible, and then you'll see subsequent ones as well. So this MEK inhibitor is called binimetinib. I was very pleased to be the lead for the UK of this study, and we participated. Now, we could see firsthand that patients had responses. In terms of the outcomes, there was no difference between standard of care chemotherapy or binimetinib. And in the updated analysis, the overall response rate was about 24% in each arm. And you can see the progression-free survival, 11.2 versus 14.1, and an overall survival in recurrent low-grade serous ovarian cancer patients that had prior platinum of around 34 months. Now I'm going to move on to the GOG 218 log study, what we called it in the UK. This was a nice example of a US-UK academic collaboration. And again, we were very pleased at our site to be contributing to this study. And what you see is the benefit of trametinib, the MEK inhibitor, in terms of progression-free survival, 13 months versus 7.2 months. And at the time of this initial analysis, published in The Lancet in 2022, median overall survival of 37 months versus 29 months. And at this Congress, we heard the important data this morning from Charlie Gawley of the final overall survival analysis, which basically confirmed and showed with mature follow-up that there was a benefit in terms of overall survival of trametinib versus standard of care treatment, which ranged, as you can see here, paclitaxel, letrozole, tamoxifen, topotecan, Calyx, the treatments that we have in standard of care practice. I want to highlight that in this study, patients were not treated previously with a MEK inhibitor. So this is MEK inhibitor naive patients. So what I also really liked in this study was that samples were collected. This was retrospective analysis, I guess, once the samples came in. So it was 134 patients, sequencing data was available. So what's important to see in a prospective study, that 33% of women with recurrent low-grade serous ovarian cancer had a KRAS, BRAF, or NRAS mutation present. There was no evidence that KRAS mutation status was predictive for progression-free survival. But what I want to focus on is the response rate here. Response is important for women with low-grade serous ovarian cancer, where you know the disease burden is very symptomatic. Patients can go into bowel obstruction, they can have hydronephrosis, they can have palpable disease, and so response is important here. In the mutation present, so that's KRAS, BRAF, NRAS, small numbers, but notable. 11 out of 22 patients had a response with trametinib, which was 50%, versus standard of care in the mutation present, where it was 9%. But then if we look at the mutation-absent patients, and I appreciate, again, the numbers here, but if you got trametinib and you didn't have a mutation, the response rate was 8% versus 7% with standard of care chemotherapy. So if we look at treatment-emergent adverse events, these are class effects of MEK inhibitors. People treating other tumor types that use MEK inhibitors will be used to this. There can be ocular toxicities in terms of the adverse events of special interest that you see here, left ventricular ejection fraction changes, pneumonitis, QTc prolongation. And you can see in the charts there, skin rash, nausea, diarrhea as side effects with a MEK inhibitor. Now, the discontinuation rates due to toxicity were 36% with trametinib and 30% with standard of care in women with low-grade serous ovarian cancer. So now I'm going to move on to avetimatinib and defactinib, and you heard a little bit about this by the discussant Shannon Weston this morning. So I just want to highlight, because these are new drugs and we may not all know how they work. So avetimatinib inhibits MEK and RAF. And RAF is on that pathway. If you look at the signaling cascade, and you're blocking two parts there. So by stabilizing the MEK-RAF complex, this can block both MEK activity and this feedback reactivation of MEK by RAF. And that is deemed to potentially be a mechanism of resistance. Defactinib inhibits FAT kinase. This is a mechanism of adaptive resistance that has been shown preclinically for MEK inhibitors and an activator of a variety of oncogenic pathways. So the idea was to combine these two. And we did this in an academic phase 1 clinical trial led by our institution. And it really shows you, again, the value of academic studies. This is an early phase study, and then you're going to see the pathway to use in practice. So small numbers again. This is low-grade serous ovarian cancer, but we could see quite clearly response rates that are higher than what we'd seen before. Low numbers, as I've highlighted, but in the KRAS wild type, around 40%, KRAS mutated, 60%. But what I found really intriguing, and I was pleased with treating patients in this trial, that we saw responses in women that had previously been treated with a MEK inhibitor. Early signals of the toxicity highlighted there. In the interest of time, I'm not going to go through details. We published this earlier this year in Nature Medicine. Based on this academic phase 1 data, this led to a Veristem-sponsored international phase 2 study looking, and I really want to focus a little bit on the design because it shows the importance of dose optimization and also contributions of, do you actually need two drugs? Do you need defactinib with a MEK inhibitor? Or how does a MEK inhibitor, MEK-RAF inhibitor, perform alone? Questions we'd all be asking. So we looked at the dose that was identified in the phase 1 study. Just to highlight, these are oral agents. The avetimatinib is given twice a week. The defactinib is given twice a day. And both are given on a 3-week on, 1 week off schedule. So patients in the RAMP 201, again showing collaboration with NGOT, led by the UK team and GOG. Recurrent low-grade serous ovarian cancer, prior platinum-based therapy, prior MEK inhibitor was allowed. And we looked at avetimatinib and then the combination, and we had a go-forward regimen based on differences in response rate. In the interest of time, I'm going to focus on the combination. But basically, if we look at the prior systemic regimens, the median was 3. Prior hormonal therapy, over 80%, prior BEV, 40 to 50%, and prior MEK inhibitors, around a quarter, okay? And then if we look at the responses, the key thing here is that the response rate with the combination, which is part of the analysis, the combination was higher than monotherapy with a RAF-MEK inhibitor. So for all patients in the combination, over 100 women, low-grade serous ovarian cancer, was 31%. In the KRAS mutated group, it was 44%. In the KRAS wild type, it was less, it was 17%. But let me remind you again of what I've showed you with standard of care, chemotherapy in terms of mutation absent as well with trametinib. So a response rate of 17% is actually quite notable here in a KRAS wild type population. The duration of response is notable, as you can see, as well. So this is the waterfall plot, and it also indicates and shows that patients also had prior MEK inhibitors, and that's showing you that overall 82% of patients had some reduction in target lesions. And the response rate numerically was higher in patients that didn't have a prior MEK inhibitor. I appreciate low numbers, and we should investigate this further. These data, together with the phase 1 FRAME data, led to the FDA accelerated approval on May the 8th earlier this year of the combination in KRAS-mutated recurrent low-grade serous ovarian cancer, and pleased that we published this earlier this year too, so you can read the details in JCO. What about adverse events? These are potent drugs. Dose interruptions due to AEs was around 80%. The majority were due to CPK increase. In terms of discontinuation for AEs, at the time of analysis, this was around 10%, and most were common was due to CPK increase as protocol directed. So 7% had serious adverse events, and there were some deaths on study, and as you can see, the reasons here, these were disease-related. So I'm just going to focus a bit more on adverse events associated with MEK inhibitors in RAMP 201. So there are some ocular toxicities, rare, but we need to be aware of them. Pneumonitis, hypertension, these are class effects of these drugs. So I'm also going to highlight some data that I'm actually presenting tomorrow, but it's an encore, so I'm allowed to show it to you today. And the reason why I'm raising this is about there's a lot of interest in ctDNA. It's really difficult to biopsy women with recurrent calcified lesions of low-grade serous ovarian cancer. So can we look at liquid biopsies? And what this really is telling you is that we should be testing the tumor based on evidence so far. And I appreciate assays hopefully will improve and our limit of detection. But there was a 44% concordance between tumor and blood samples. Indicating that there may well be this tumor, low-grade serous ovarian cancer, may not shed as much as some other cancers like endometrial cancer or high-grade serous. So this is going to bring me on to the RAMP 301 study, a true, as you can see by the logos here of the collaborating groups, a true international study. This is a global phase 3 study looking at the combination of avatimatinib and defactinib versus investigators' choice of therapy. Prior MEK inhibition, again, is permitted, and we built in the ability that if there's BICA confirmed progression, patients can cross over to the avatinib and defactinib arm. This continues enrollment, and I'm very much looking forward to the results. I'm just going to mention some other pathways. I mentioned at the beginning the relevance of endocrine pathways and treatment, and I think this needs to be explored further. I think there's a lot of merit in this. There are other targeted therapies, targeting angiogenesis, for example. There's some nice retrospective series data, bevacizumab responses, and also hormonal therapies. And I'd like to highlight GOG 3026, led by the GOG team and the chair today, Brian, with ribociclib and letrozole in patients with low-grade serous ovarian cancer. Look at that waterfall plot. Look at some of the durations of staying on treatment, and confirmed responses above 30%. So I think this is a really important combination, and we need to explore this further and use this further. On the theme of endocrine treatment, this is neoadjuvant fulvestrant with another CDK4/6 inhibitor, abemaciclib. So neoadjuvant, but interesting response rates here. And again, we need to think about downsizing this disease, hopefully operating on patients. And of course, maintenance or adjuvant therapy in the first-line therapy setting with the MD Anderson data, retrospective series that was published some time ago, raising the hypothesis post-chemotherapy about maintenance hormonal treatment. And there's the NRG-GY019 study, which is looking at patients with stage 2 to 4 low-grade serous ovarian cancer with chemotherapy followed by letrozole or letrozole. So let's await these results. So I hope I've shown you that clinical trials are changing the treatment landscape for advanced low-grade serous ovarian cancer. And let's use this principle for rare cancers. Systemic treatment options improving. We've talked a lot about MEK inhibitors, but I also think endocrine therapy combinations are notable. Avetimatinib and defactinib, combination in KRAS-mutated recurrent disease, is the first approved treatment for women with low-grade serous ovarian cancer, and I'm truly honored to have led that program. And phase 3 RAMP 301 results are awaited. It's a confirmatory trial, but of course we're looking at KRAS mutated, but also the KRAS wild type population, and I look forward to the results. Thank you for your time.
Yeah, really. A shout out to Susanna, Rachel Grisham, David Gershenson, friends and really mentors. They're really doing a great job in changing the bar, which is super exciting. Without further delay, I want to again congratulate Sakith for helping co-lead an amazing meeting. So he's really, I'm so happy to be a part of it and to be here. And it's a lot of it for all of us is due to the hard work that he's done. I've never seen a program director work so hard to get so many people here. With the average flight was probably like 18 hours from the U.S. I'm going to introduce him now, Dr. Gwentupalli, to discuss the role of biomarker testing and sequencing in treatment selection for our patients. Sakith?
So, good afternoon, everyone. I'm going to talk about the role of biomarker selection and how we sequence treatment. I'm going to speak for just about 15 minutes because I think that the important part of this talk really is kind of the back and forth, the Q&A. One of the things that I think we need to remember is that low-grade serous ovarian cancer is a pretty rare entity. It's not something that we actually see very often, and so I would say it's hard for any one person to be a true expert on this topic. Clearly, there are experts that are out there, but because of the rarity of the disease, I think that really the back and forth, how we think a little bit outside the box in this space is really important. So how do we sequence treatment for low-grade serous ovarian cancer? The first thing I want to say is it's really, really important for our medical oncology colleagues in the room that we really, really think that surgery and know that surgery is really the upfront mainstay of treatment. Complete surgical resection of this disease process to R0 is really, really the thing that we need to start with. And I would really encourage everyone to please partner with your surgery colleagues in this regard. Again, the goal is R0 resection in this disease process. It's a goal in any really cancer surgery, but particularly for low-grade ovarian cancer, that's really going to be one of the biggest predictors of your survival. Again, consultation with other services is vital, consultation with your G1 oncology colleagues, but as well as your surgical oncology colleagues to do a peritonectomy, to really remove all of that disease is going to be of vital importance. And then where do we go from there? After you get your diagnosis of a stage 3 low-grade ovarian cancer, you want to ensure that you're engaging in really, really good molecular and targeted therapy testing. So what are we looking for? Dr. Banerjee really kind of hit the nail on the head that the marker that we really believe now is going to be so vital in low-grade ovarian cancer is KRAS. But there are other things that we want to look for, and I'm going to talk a little about that. We want to look at folate receptor. There is, pretty decent data that I'm going to show that this is an important biomarker in this space, but really that KRAS mutational status is going to be the most important. Treatment with chemotherapy. We know that their response rate isn't great with cytotoxic chemotherapy, but it is still part of the armamentarium. Anti-estrogen and hormonal therapy using aromatase inhibitors, and what is the maintenance therapy that we have to think about in this disease process. A lot of these patients are obviously going to recur, so what happens when they recur? Well, if they have a long DFI, a long disease-free interval, and it's oligometastatic recurrence, just a couple sites that you can see on your CT scan, I would encourage talking to your surgical colleagues about surgical resection and re-debulking these patients. But again, that's individualized, and that's something that needs to be discussed extensively. MEK inhibitors, we're going to talk about that. Trametinib is something that many of us have used in this space. It's really the only thing that we had until Avetimatinib and defactinib were approved. Clinical trial, I would really strongly encourage everybody to consider clinical trials. The only way we're going to make any advancement in this space is to put patients on clinical trial. And then obviously palliative care is going to be an important part of this as patients continue to progress. So what are the molecular and clinical features that drive biomarker testing in low-grade versus high-grade ovarian cancer? I think we all know that the key biomarker in low-grade ovarian cancer is going to be the HRD status or the BRCA status. In high-grade, we know that that is the key biomarker. But what about low-grade? Things like BRAF, KRAS testing are going to be incredibly important. We need to remember that these patients tend to be a little bit younger. And the thing that I would really encourage everybody to keep in mind from a pathology point of view is that if you have a patient, particularly who's getting neoadjuvant chemotherapy, that does not respond well to platinum-based doublet in the neoadjuvant setting, to really think about, is this truly a high-grade ovarian cancer? I say that because I'm actually doing this on Tuesday. I have a patient who has not had great response, even though my pathologist has read it as a high grade, has actually had a pretty terrible response to neoadjuvant. And on a few times, what's happened is when I take them to debulk them, it comes back as a low grade. So, something to keep in mind. Again, response to neoadjuvant chemotherapy with low grades tends to be pretty low. Response to adjuvant chemotherapy even lower. And again, the rate of hormone positivity and that hormonal status is going to be really key in this disease process. So again, to summarize clinical characteristics of our low-grade patients, again, something to really keep in mind, these tend to be younger patients, tend to be a little bit more aggressive. They're not driven by BRCA and HRD status. I want to talk a little bit about other biomarker testing because we talked a little bit about KRAS, and I'll talk a little bit about that in a second. But one of the things to keep in mind is that some of these tumors, in fact, many of these tumors may express folate receptor alpha. And again, the percentage of FR alpha that they're going to express may vary, but in terms of just looking at it dichotomously of expression or no expression, a decent number of these patients are going to express folate receptor alpha. So that does potentially open up the source of these targeted therapies for these patients. So I would say from a biomarker standpoint, if you're getting your NGS testing, if you're getting your IHC, definitely talk to your pathologist or whatever company that you work with to look at this biomarker testing. What are the molecular mechanisms that are altered in this pathway? Well, again, it's really going to be KRAS. This is a nice data that has been presented, and you can see here in low-grade cancer, which is that dark bar there, not the yellow bar or the blue bar, but that dark bar, that of these kind of targetable agents, or of these mutations, it's really going to be KRAS that is the most expressed in low-grade ovarian cancer. BRAF to some extent, P53 to a small extent, but really it is KRAS that you're going to really want to look at. So I would strongly encourage, if you get low-grade on your pathology, to talk to your whatever company that you're using or with your pathologist to get this testing ordered. So what are some other key markers? What is the kind of sequencing of this biomarker activity? Well, again, you're going to do your initial assessment. CA125 is going to be a marker in these patients. Unfortunately, it's not the best marker, but it is a marker of peritoneal inflammation and peritoneal irritation, so you can use it certainly in the recurrent setting. Again, not as great as high-grade ovarian cancer, but something that we could potentially use. Again, establishing a definitive diagnosis is going to be key, and expert pathology review. If you're in a center that isn't very used to looking at low-grade versus high-grade ovarian cancer, then I do think it's going to be really important to make sure that you have a pathologist that knows the difference and can really make that distinction, because again, it is really going, and if you can know that pre-surgery as best as you can, it's really going to make a difference in what your surgical approach is and how you approach these patients. So again, having that great pathologic review is going to be really important. And again, second opinion in this case is going to be vital. And then what are the key clinical biomarkers or key biomarkers that we look at? Again, KRAS, BRAF, NRAS are going to be the three that you're going to look at, but KRAS is clearly going to be the one that's the most important. And how is this predictive? It is a predictive biomarker testing in this space. When you look at where we are in this space, you can see these are the targeted agents or targeted therapies that we see, and we can go through them kind of briefly. Obviously in high-grade ovarian cancer, it is going to be that BRCA and HRD status. Pretty unremarkable with the low grade, but if you do by chance find one, you could potentially use a targeted therapy there. Again, we test in our practice, all of our patients undergo HRD testing that are high grade. Again, folate receptor alpha, if they were to be positive and express 60, 70, 80% FR expression, then you could potentially use something like mirvetuximab. Again, HER2/neu, MSH, MSI expression, all could give you those targeted agents. But really the one that is the most important, again, is going to be, that KRAS mutational status. And the reason that we're all driving that home is really when you think about this disease space and when you think about where we are in low-grade ovarian cancer, really until the approval and kind of the recent study that Dr. Banerjee talked about, the RAMP trial, we really did not have anything new in this space, and now we do. So it's really exciting. So that's why we are really emphasizing the need to test for KRAS. And again, when you look at it, is there concordance between blood and tumor? This is where kind of some of your ctDNA may come into play. Again, there is reasonable concordance between tumor and blood samples in which the KRAS mutation was detected. So you do have some options there. So that's really all I have for right now. Again, I think that the most important part of this is going to be this kind of back and forth interaction we have. Again, when we sequence these when we sequence how we do biomarker testing and how we treat this disease process, I think the key takeaway points are, number one, that surgical debulking is going to be the mainstay for treatment. Number two, highly, highly important in the adjuvant setting is knowing that KRAS mutational status and thinking outside the box. And then there's kind of these decision points. Do you start with trametinib? When they recur, do you go straight to trametinib? Do you go to this doublet oral therapy? Do you go for clinical trial? None of them are incorrect or wrong, but I do think that what all of these studies show is it highlights the ability that we do have more options in a difficult space. Thank you.
All right, so first of all, it's very unusual for this meeting. I want to congratulate our speakers for finishing early. How about that? So I'm going to we're going to go through these cases now. Here's an option. I have this machine up here. If you want to, if you're shy and you don't want to come to the microphone, you could scan the QR code and type your questions in there, and I'll get them posted up here. Can we turn the lights on a little bit in case someone comes up? Then I'll be able to see them. Is that possible from the AV team? In the room? If you can. Okay, key discussion points. And then again, please, guys, please, we want to make this as interactive as possible. Either type in your questions or come to the stand up. I don't know if there's a microphone. Stand up and give us some of your questions. Oh, there is a microphone in the back. Can we turn the lights up a little bit? If we can. Okay. But if you have a question, you want to use a microphone, Corey's in the back. You can either find her or put a blindfold on and try to find her. Question? The microphone is right behind you. Good. And we have plenty of questions on our own to go through.
So these questions are not related to case presented, if that's all right to ask.
You could ask anything you want. Yeah, please.
So I have one patient who is in mid-30s, presented with advanced ovarian cancer, suspicious of low-grade cancer. She also had disease in her breast. So we took her for primary debulking, and we had general surgeon consulted as well. We were able to debulk, I would say, percentage-wise 90 to 95%. We had to leave some disease on bowel mesentery and bowel serosa. Obviously, the breast was left untouched. She also had disease on her gallbladder. She had gallbladder surgery a year ago, and on port side, she had cutaneous metastasis. So resected all those things. Now she's on carboplatinum paclitaxel. She's like 27, 28 years old, very, very anxious, she has 2-year-old child, and she wants to know, am I doing the right thing? I was thinking that once we finish carbotaxel, I'll put her on letrozole and get KRAS testing, and we go from there. But her breast cancer, what has happened, that her mammogram was done, and then the breast people started to biopsy breast, low-grade cancer, and then they follow up with MRI breast. Like, they are just not listening and keep diagnosing and investigating her breast lesion. So my question was that, is there any role of doing anything different at this point, what I am doing, carboplatinum paclitaxel? And
Yeah,
do you
so-
do, after 3 or 4 cycles, do you offer a CT scan to see if there is any disease progression while she's on treatment? And if there is, would you alter management? That's one question. And this,
Yeah, let's attack these questions first. So
Okay.
for those that didn't hear, the question is, it's about a very atypical presentation. It sounds like she was diagnosed with a low grade in the typical fashion. Now, is the breast cancer different, or they think it's a low grade?
Same.
So she also had metastases to the breast cancer. I'm going to ask our panel some questions, but the first comment I'm going to just say, when we think about these cancers, and there was a nice chart differentiating low grade and high grade, I think about these cancers more like an ER-positive breast cancer. Because when we go through the treatment options, a lot of the biomarker testing, it's similar to that, especially with the hormonal management and some of the CDK4/6 inhibitors. So it's interesting she had both, but Suzanne, I'll start with you. It's very, very interesting, complicated case. And it sounds like you're also having a struggle with your internal colleagues about which direction to go in, emphasizing the need for multidisciplinary conferences. But Susanna?
Great. So first point, and I think you've just confirmed that, was the breast biopsy. So that's low-grade serous ovarian cancer. So the management is regarding the primary, yes? So I wouldn't be involving, unless it was from a palliative perspective, a breast oncological team, okay? So because it's metastatic ovarian cancer. So the treatment is driven by the histology, not the location, of the metastasis. So that's the first point. I'm glad she had surgery. I think, understandably, and we always aim for no residual disease, but that's not always achievable. And I think in low-grade serous ovarian cancer, my personal viewpoint is actually reducing the disease volume is very important from a symptomatic point of view as well. And it sounds like most of the disease, or a majority of disease, was removed. And so I would give carboplatin and paclitaxel, as you've mentioned. I certainly would image after 3 cycles, because I'd want to know if the patient is benefiting from chemotherapy. I know I've highlighted response rates of chemotherapy being low, but that was in the recurrent setting, and I didn't have time to show you that subset analysis, for example, in ICON-7 and other studies, does show that women with low-grade serous ovarian cancer enrolled into those studies, albeit subgroup exploratory analyses, there can be a response, and response rates can be in the order of 25%. Okay, so, and I certainly clinically have seen women benefit from chemotherapy in that advanced stage 4 setting. So I would do a scan to check, and if there's no progression and chemotherapy is tolerated, I would continue that, but hand in hand, as you are doing, thinking about what you're going to do next, because that next is going to be quite soon, most likely. So I would, if possible, do KRAS mutation testing, but equally as well, I think you mentioned there was serosal bowel disease, so you've got to think about risks of bowel perforation, fistulation. So is bevacizumab an option for this patient? Sounds like it might not be, but otherwise I would add in bevacizumab. And I certainly would be thinking in this situation, as you've described, which I'm sure Brian will be saying as well, giving letrozole, presuming there's no progression at the end of chemotherapy.
Yeah, just to comment on that, I mean, and spot on. Remember, we have the NRG trial, which is carboplatin and paclitaxel followed by letrozole versus letrozole alone. So I think hormones up front is still under clinical investigation. There's a data by Cobb and Gershenson from Anderson looking in the neoadjuvant setting of abemaciclib and letrozole. So I agree right now the standard of care would be carboplatin and paclitaxel, but future directions. And my only other comment, this is not traditional, I don't know if I recommend it, but the nice thing about the breast disease, if there's anything nice, it could be a good biomarker of response, because you'll be able to, on clinical exam, see how that goes, see if you're responding even without imaging. But please, and we're getting questions in, which I super am excited about.
Same for the cutaneous lesions that you mentioned.
Yeah, so I resected those. So now she doesn't have those cutaneous lesions.
And you had a follow-up question?
Yeah, so that's okay. I think I'm okay right now. We'll see how it goes. My second question is mid-60s, low-grade ovarian cancer was taken for primary debulking. We had hepatobiliary surgeon, colorectal surgeon. They declined to perform any debulking. So we had open and closed situation.
Yeah, I mean, Saket, what are some of your thoughts on?
Yeah, I mean, I think that, using your surgical colleagues, I mean, they have to make the surgical decision because they know, their kind of organ, if you will, about. So if the colorectal surgeon doesn't think it's safe for whatever reason, or they'll lose too much bowel, they'll lose too much, colon, then, we have to defer to them. But what I would say is, it is really, really important, in particular in this disease process, to really consult with your surgical oncology colleagues, your hepatobiliary surgeons, your upper abdominal surgeons, because as G1 oncologists, we do feel very comfortable in the abdomen, but there may be some things that we don't. But in this disease process, I think that R0 resection is going to be the most important thing. I have one question about your previous patient. Have you resected the breast disease? Is it resectable?
I didn't, because we didn't know at the time.
Right.
She had lesion in both breasts. I mean, I can refer her to a breast surgeon to see for possibility, but we did not resect thinking it was a metastatic disease.
You thought it was a different primary.
I mean, I think sadly from experience with patients, because I've had patients with cutaneous disease with low-grade serous ovarian cancer and also breast metastases, that actually the process has happened, and then in terms of surgery at this stage, if it's bilateral, do you see what I mean?
Yeah.
It may well go somewhere else. I wouldn't be surprised if cutaneous other lesions appear. So I think systemic treatment is key. But certainly, if there is a palliative element, by that I mean symptom control because of the breast lesion, that's a different matter.
Yeah, let's keep going. Those are great questions. I think they also highlight the multidisciplinary approach to some of these patients for people who know this disease, but also a lot of times colleagues aren't familiar with this disease.
Yeah, but they declined. Close, now we have no way to do other things.
So thank you for that. Our next question, I'm going to go right back to Saket. Is there a role of HIPEC in the first line or recurrent setting for this disease? And a lot of patients don't know this, so I'm not trying to put you on the line, but what are your thoughts?
No, I mean, it's an interesting question. We've actually talked about that. There is, reasonable data that some of the molecular markers in things like appendiceal cancer, in GI malignancies, in, pseudomyxoma peritonei, those things, are similar in low grade. So, and, they use HIPEC in those diseases. So there may be, I just don't think that we have enough data right now, but is the answer possibly yes? Maybe in a patient that is, young, healthy, can tolerate an extensive surgery, I don't think it would be unreasonable. I don't know, Susanna, what do you think?
Yeah. And I think the experience with HIPEC is improving,
Right.
Across malignancies. So, whenever we're thinking about any treatment, it's that balance, isn't it, about efficacy as well as toxicities, comorbidities, etc. So, as that learning journey of using HIPEC is improving, I'm not aware of prospective clinical data in low-grade serous ovarian cancer specifically. But I imagine that people will have some experience, and perhaps that's the value again of real-world evidence as well.
Yeah. No, thank you for that. Let's keep going. I mean, it's great. We have a lot of questions to go through. I'll start with Susanna on this one. Considering the importance of KRAS mutations in low-grade serous ovarian cancer, what is your experience? What do you think about KRAS inhibitors in this regard, and also mTOR inhibitors in this regard?
Okay, so I think targeting the MAP kinase pathway, so whether it be a KRAS inhibitor, we're seeing in early phase clinical trials that have been reported, and I have time to show you all of them, different KRAS inhibitors, different MEK inhibitors. We're seeing a similar principle in terms of efficacy. I think if I had a clinical trial of a new KRAS inhibitor, for example, then of course, as you highlighted in your introduction, I think you did as well, with regards to the importance of clinical trials. With regards to the mTOR pathway, again, many of us have explored this pathway for
quite some time, and in particular also in breast cancer, as you mentioned, as well, and in terms of endocrine signaling pathways with the mTOR pathway. I've done some studies in high-grade serous ovarian cancer with good preclinical and early phase data, but it didn't translate to in the randomized phase 2 setting. But I haven't specifically in low-grade serous ovarian cancer. But we've all had anecdotes in clinical trials where, in fact, I did a study of abiraterone actually a long time ago in ovarian cancer, and some of the patients with ovarian cancer that benefited actually had low-grade serous ovarian cancer. So I think it's the principle of those endocrine signaling pathways and those interactions, for example, with mTOR pathways that we haven't manipulated enough, but we know a lot more about molecular biology now, and we're able to test a lot more, so perhaps this should be redone.
Yeah, no, and I'm a big believer of like the mTOR inhibitors overcoming hormonal resistance, so it makes sense to use them. Saket, I know you've used this in your practice, right? I think a lot of us have put patients on trials, but you've actually prescribed it. This is an example of a case: recurrent low-grade serous ovarian cancer, third recurrence, unresectable in the third. She's had previously carboplatin paclitaxel and previous trametinib. For this patient, would you consider abimetinib and defactinib after those two therapies?
The KRAS mutated, yes, absolutely. So we have one patient on, and it's been interesting because, again, this is a rare disease, and anytime you start with a new drug, you're obviously, you have worries. So what is one of the big side effects of this doublet combination that we're not used to seeing, certainly in G1 oncology, is that increase in CPK and possible rhabdomyolysis. That's something that can be devastating. So I've seen one case of that in my whole career. Patient came in fulminant renal failure, CPK through the roof, and it's devastating. People die from that. So those are things that you have to kind of watch. You've got to watch the bilirubin in these patients. Nausea, GI side effects are probably the biggest side effect that we hear with this drug combination. The other thing to keep in mind is, and again, this is a new era for us, particularly with ADCs, is ocular toxicity. So double vision and blurry vision is a side effect of this drug combination. It's mainly the GI side effects, but those other things can happen. The GI side effects we're very used to managing, right? Because we give platinum-based chemotherapy all the time, so we're used to that. But the other side effects, I think, are important to keep in mind. So just something to think about. One thing I do want to add that is a side effect, not necessarily of the drug, but of certainly the surgical treatment, is we have a young patient who's 35 that has a BSO, are the menopausal side effects. So that's another thing to really keep in mind. But patient's doing okay on it. Just got this patient on, so I don't even think we've done her first scan yet, but seems to be doing okay.
Yeah, well, thank you for that. And also, if there's anyone in the audience who has a fair amount of experience, we'd love to hear from you as well, because, again, the interactive nature of this. Keeping going, this question is relatively straightforward and simple, so I think I could answer the next one. In your practice, are you still giving adjuvant carboplatin paclitaxel to all of your low-grade serous ovarian cancer patients, or do you go straight to maintenance letrozole? I think that's a good question. I think the bottom line is, what stage is she, right? And what are some of the characteristics of the spread? In my practice, I'm giving chemotherapy if there's extra ovarian spread with invasive implants. If there's non-invasive implants or limited to the ovary, then I go right to letrozole maintenance. If it's invasive implants or more, then I'm a believer right now of carboplatin paclitaxel followed by letrozole maintenance. Any thoughts, any differences?
I think it's a bit like your question, actually, with your case, isn't it, about the staging and whether to give adjuvant treatment. I do give adjuvant carboplatin and paclitaxel for advanced stage 3, stage 4 disease. If there's residual disease, then, and it's safe to do so, I would add in bevacizumab. In the UK, in England, in the NHS, we have one opportunity to use bevacizumab, which is in the first-line setting. So, and given, albeit retrospective, data that I mentioned of bevacizumab, I'd rather just use that early on. But it's really, interesting to think about the letrozole approach, maybe letrozole with bevacizumab, if that's the case in the first-line setting as maintenance therapy, but also thinking about duration of therapy as well.
Yeah.
How long do you give the letrozole for?
Yeah, no, those are great questions. Speaking about surveillance and starting someone and figuring out how long, Sackett, CA-125s, CAT scans, what ctDNA? Let's hear about what your thoughts are.
So we talked a little bit about potentially using ctDNA. I don't believe this is the best histotype for that, but I think it's certainly possible. I think, I did present a little bit of data on that, and can you use ctDNA, and you pick your test of choice to do that. But I don't think in this particular space it's probably the best, but I think it's not incorrect. What I do in my practice is I still use CA-125, mainly because it's something that we have, again, not the best in low grade, but if it's elevated at the time of diagnosis, it can be a marker of recurrence. I'm a big believer in imaging in this disease site particularly, because I think that you want to catch things as they happen before they get out of control, even though you may not have something if it does get out of control, but I certainly want to know so I can counsel the patient. So I actually scan them every 3 to 6 months. It's probably a little overkill if you talk to maybe other colleagues, but I think that it is a reasonable thing to do in this disease process because we don't have something else. Whereas in a high grade, the CA-125 tends to start going up, and I can do that. And then I have got ctDNA that I can also rely on. So imaging, I think, is important in this process. What do you think, Brian?
Yeah, no, I agree. If the CA-125 is elevated at diagnosis, then I follow the CA-125 as well as intermittent imaging. But as we know, some of these patients, it's not elevated, so we can't use it as a marker. ctDNA, I think it's a great tool, but I think for low grade, it's not ready for prime time. I think is worthy of investigation as far as treatment duration maybe, or need to give treatment, but that's what I'm surveying. I want to get to some of these questions, and we heard about biomarker testing from Sackett, so Suzanne, I want to hear from you. When are you testing? Are you on these stage 1A patients that are limited to the ovary, are you getting the KRAS testing then, or are you waiting until later? And then how does this testing, if you're doing it early, affect your discussion with your patients?
Okay, so there's what I can do and what I'd like to do, yes? Because remember, I come from an NHS National Health Service environment in England, okay, so, which I think many of you may be able to relate to. So resources are an issue. We have to think about that. But having said that, even if I had a stage 1 patient, knowing the KRAS or BRAF mutation is not going to change my treatment for stage 1A disease as it stands today. So I wouldn't be doing that. Having said that, the reason to do that is, as you probably know, if some patient does relapse, it's about getting that sample and then testing then, and you have to ensure you can do that in a timely fashion. And sometimes having a test early on when you've actually got the diagnostic sample and you're about to treat them, it's a bit like the folate receptor conversation in high-grade serous. You've got the sample, let's just do a panel of things that will be helpful in the future. But I wouldn't be pushing for this in the priority of things in low-grade serous ovarian cancer in early stage, but I certainly would want to know it in recurrent disease, okay? Right. So, but even as we stand today, that is not an NHS-funded test in low-grade serous ovarian cancer for recurrent disease.
Right. So I'm from Florida. I can pretty much do anything I want. I get ER/PR positivity. I do P53 because I want to see if they're wild type or not. I do alpha folate receptor testing, and of course I do KRAS testing because I think it's important in our minds to plan out. So I know you do what you can do, but I think it's important to plan out. Sackett, any do?
I totally agree with you. I'm in a high resource setting, and our practice has adopted a completely molecular approach to all of our cancers, so we do all the testing at diagnosis. We have our own lab for a lot of things, so we're a little lucky in that regard, and anything else we're able to send out and generally get covered, but I would agree, I want to know. I agree with Dr. Banerjee, though, in an early stage, like 1A, where you may not do really anything, I think it's reasonable to wait if you can. We've just protocoled everything, so we don't even have to think about it. We have people that do it for us, and then we just get a report of their entire molecular profile of their tumor. But that's a little, we do that across all of our invasive cancers.
Susanna, any data on KRAS status in primary setting changing? I mean, I know some of these are heterogeneous diseases, but this is an audience question. I'm not trying to put you on the spot. Some from the audience is.
No, don't worry. I don't think we can say that for now in terms of, and this is, again, brings us back to the value of repeated samples. But you could argue, just thinking about that ctDNA data that we presented within RAMP 201, that, we are identifying the KRAS mutation for the comparison in largely the archival samples, which would have been at diagnosis. If we were doing this as an experiment, I guess, you'd want to biopsy at the time of when you're collecting that ctDNA, for example, and to see, if there's a change. But, this is the problem, across different tumor types, whether you can rely on the archival status or does it change. And it's not just time as a variable, it could be the sample you've tested. It's the heterogeneity within where you've taken that sample. We know that with HRD status, for example, we are acknowledging that in folate receptor testing too. So I think that I'd be happy with the baseline sample, because I think I imagine that's going to be of relevance. I don't think there'll be substantial changes from data we know so far.
Yeah, in the recurrent setting, sometimes we're limited by disease availability. A lot of times this is a surgical disease, so if it's been a year or 2 years and they're operating, we have tissue, I'll probably send it off. Again, we don't have some of the same restrictions that you have, so I would probably send it off. I'll take this one from the audience. What is the role of CDK4/6 inhibitors with hormonal agents as maintenance therapy after cytoreductive therapy? So remember, we mentioned the team at Anderson is looking at neoadjuvant, and we're about to report, it's in press and JCO, about our experience with ribociclib and letrozole in the recurrent setting. A couple things about the trial and the characteristics of CDK4/6. When I presented it at SGO a couple of years back, the response rate was 20%. But by the time I got over my procrastination and we got the paper written, the response rate went up to 30%. So what we are learning about these is there's this long, stable disease process, and then eventually the stable disease process can turn into a partial response. So it's sort of a long, remember, these aren't cytotoxic, they're cytostatic agents for the CDK4/6s and letrozole. The trial accrual was a bit limited because we did the CDK4/6 plus letrozole due to the implementation of the MD Anderson regimen of hormonal therapy. A lot of patients had letrozole. We didn't allow for that, so it extended some of our accrual. The data right now, it's all in patients with treatment. CDK4/6 inhibitors do have some toxicity. They're more toxic than letrozole alone. In the absence of data in the adjuvant setting, we're using it with disease to see a response and try to limit it. I feel comfortable giving it with fulvestrant, even though some more limited data there. And anything to add on the CDK? I know I just gave a little bit of a summary, but anything further to add with CDK4/6 in this setting?
I think we also need to, as we talk about multidisciplinary, learn from our breast colleagues as well, with the use of CDK4/6 inhibitors. I think the idea of maintenance therapy would be a wonderful trial. In terms of combinations in the maintenance setting. Yeah,
again, for me, it's breast cancer, ER-positive breast cancer. So this is a lot of good questions. We'll finish up with some I think we have to get through here. In this disease, what is treatment resistance? What is platinum resistance? What do you think? Sakit, what are your thoughts on that?
So that's a great question. So I would say stable disease in a patient that's generally asymptomatic is a massive win in this disease process. And the reason is we probably all have that one low-grade patient that recurred, and I have a patient that I put on, an AI, and she's been on that AI for 3 years, stable disease. She has side effects, I'm not disputing that, but she's stable disease, but generally has, a performance status of, of a 0 or 1. I mean, she's generally doing pretty well. So I think that, again, when we look at treatment resistance, I think we have to be able to say that stable disease in patients that are, largely asymptomatic is a win. And I think that, this idea that we have to have a complete response, that stable disease is not necessarily treatment resistance, that in fact it might be the outcome that you're looking for. I think that's
Suzanne?
I don't think we should be using the term platinum resistance in low-grade serous ovarian cancer.
Agree.
You can argue if you should use it at all in any, but I don't think we should be using it. I think we should be reserving that term where you actually can have a more higher response with platinum to justify potentially using that term. But I would really get away from that 6-month platinum-resistant terminology in low-grade serous ovarian cancer for sure.
It's not really platinum resistant if platinum doesn't work, really work. So.
Yeah, and I think those are great answers. For me, a lot of times nowadays, as you know, patients could read their CAT scan report before we even see it. So they'll come in, they'll say, oh, but what about this and this? My question to them is simple. If you could live like you are today for the next 20 or 30 years, would you take it? And most of the time they say yes. So it's, again, it's not what they want. They would love to have a clear CAT scan, but as we're, sort of emphasizing the stable disease role, I think is an important and a beneficial outcome for our patients. We're talking about chemo in the first line, hormonal in the first line. Susanna, when are we going to bring some of these biomarker-driven therapies to the first-line therapy? Do you think that's what we need to do, or leave them where they are now?
No, I think that we want to, like the principles of all the gynae cancers and other cancers that we treat, that we want to bring best treatments early on if there's a potential to cure more women. So, but we need to do the trials in order to do so. And perhaps in low-grade serous ovarian cancer, that may be more acceptable in the first-line setting because, as we've talked about, the response to carboplatin and paclitaxel is not the same as in high-grade serous ovarian cancer. So I do think, and I'm aware that Rachel Grisham, who I just want to put a big shout out for her because it's been great working with her on the RAMP programs with this from a GOG perspective, and I know that she's leading a neoadjuvant, I guess the term is, preoperative to have a look at the responses in that setting at Memorial Sloan Kettering. So I think that we need some evidence to support it, which I'm sure that will be generated. I'm sure people will be doing investigator-initiated studies to that effect. But we also need to balance all the time toxicities as well. I just want to, highlight that there will be class effects of targeting the MAP kinase pathway. And so we as a community, I don't think we're going to find a drug that doesn't have toxicities, but we as a community need to know how to better manage and identify and predict, perhaps risk stratify patients according to the likelihood of toxicities. So, and I certainly think that we're much better. As I said, I was involved with the binimetinib study, the trametinib study, and now these studies. We're better at treating skin rashes. Yeah. We're better at giving prophylaxis. We know what to do. We know how to cancel patients. We know to look out for, because of immunotherapy and other treatments, we know to look out for pneumonitis, and we know what to do with that. Rare as it is with these drugs, we know to look out for it. And similarly, you mentioned ocular toxicities. We are becoming more aware of that with, from our lessons in high-grade serous ovarian cancer or cervical cancer with ADCs. So I think that as we bring things forward and in the patient pathway and also potentially as maintenance treatment options, we need to be acutely aware of what's tolerable and for how long for. I can say within the RAMP 201 study, for example, I've had some patients I'm privileged to have looked after who've been on this for several years, and in fact the phase 1 study as well, I have a patient still ongoing on this. So it can be done in terms of durability of response, non-progression as you highlight, but also side effects.
Yeah, no, I think that was great, and I think you alluded to this, but one of the nice things, and I think this is a big reason why we got an FDA approval. The world is a smaller place. We've done the RAMP series of trials globally, and that's we've gotten patients on trials, and we could come to bigger answers more quickly, which I think is important. I know both of you are very strong advocates of the clinical trial pathway, and we encourage folks in the audience that we really need to put these patients on clinical trials, so we appreciate the support there. We're almost done, Suzanne. I'm good for the tough question. Why is the Milo study negative and the 281 positive? And just to remember, these are two MEK inhibitors that she brought up during the talks today, and she was involved with. So what are your thoughts there?
Well, I think, of course, we're not meant to do cross-trial comparisons, but, there are different criteria, yes? So if you look at the comparator arms in the academic GOG and log study with trametinib, we allowed hormonal therapy as a standard of care option. That wasn't the case, for example, in the binimetinib study. Also, the number of prior lines is going to have an effect as well. So I think we were all surprised. I think that if you look at the binimetinib activity, it's in line, on a par with what we'd expect or what we've seen with MEK inhibitors. There is a range, but it's within that. It's the standard of care arm in recurrent prior platinum-treated low-grade serous ovarian cancer that did better, if you like, than what we expected, similarly in terms of PFS. So I think there's that aspect. I think investigators and those of us involved in the trial at the time were quite surprised by the outcome of Milo. But there's no doubt about we saw the OS benefit today confirmed in the GOG log study. So I think it really shows the principle of MEK inhibition. And just to highlight again that this was done in an era where no prior MEK inhibitors were allowed. So, for example, with avetimatinib and defactinib, we knew that patients would have had a MEK inhibitor, most likely in the context of a clinical trial. So, that's important to take into consideration as well when we look at RAMP 201 and RAMP 301, which I hope to do at some point in the next couple of years. Yeah.
Last question before we finish up, Sakif. Alpha folate receptor mirvetuximab has an FDA approval across all ovarian cancers, including low grade. What are your thoughts about ADCs in low grade?
So I'm actually a reasonably big fan. As I showed in the data that I presented, there's a decent number of low-grade ovarian cancers that are going to be folate receptor positive. Kind of the extent of that positivity and kind of what we look at in high grade, is clearly well defined from the studies that use them. So I think that, it's part of your armamentarium. Certainly, I think that in a patient that's recurred, that's progressed on trametinib, on AI, on the dual combination from the RAMP study, I think that absolutely you could consider using it, and you should use it, particularly in someone that has an excellent performance status. I do think that there's some things to keep in mind that, no treatment is free, and all treatments have their side effects. The ocular toxicities with EDCs, and particularly ones that tolerate folate receptor alpha, are not without their risks. I mean, I have a patient right now who is really, really suffering from bad ocular toxicities on an ADC. And so I think it's just something to keep in mind and to balance that with, potential response. But I think the key here, as I think Dr. Banerjee and I think that you said, is, what is our goal here? I think our goal here may really be stable disease.
Thank you for that. Wow, I'm so honored to be on this panel. Really a great discussion, guys. We covered a lot. We covered most of the issues in low grade. This concludes our symposium. We really need to thank first the IGCS. What a great meeting. The GOG Foundation, we help run these industry-sponsored symposiums, so shout out to the team who does that. Very importantly, Veristem for their financial support of this conference. The session will be available as part of the IGCS On-Demand Enduring Material Program following the meeting. Thank you very much for being here, and have a great afternoon. Enjoy the rest of your meeting. Thanks, guys.
Thank you.